All right. Well, thank you all for being here. We have with us Dr. John Robert Walker, who grew up in Bluff Park in the community, grew up in the Hoover area, of course, and was a member of Bluff Park United Methodist Church, and is a person that we turn to often for medical advice. But he's also somebody that, if you've ever been to one of our barbecues, you know he's going to show up at some point to get a little bit of that. John Robert, we are so thankful that you're with us today. And I just wanted to say that we're so appreciative not only of you, but for everyone who is in the medical community in some form or fashion, who is on the front lines dealing with this and serving people. We know that people who go into this line of work do so because they have compassion, they have a feeling of duty to serve others and to put the health of the patient above everything. And so thank you for what you're doing. And I'm sure you're taking on a little bit of risk in this as well.
I appreciate that, Mike. And I certainly hope to embody those very kind words that you threw out there. It's certainly a challenging time that we as a community face. And I think that there's a lot of disinformation, a lot of misinformation, and a lot of hoaxes that are being passed around from person to person. What we're dealing with is a brand new virus that we have never seen. It's a SARS type virus, which that kind of harkens back some memories to the SARS quote unquote pandemic there. But that's just a way for doctors and virologists to keep track of different types of viruses. It's called a coronavirus because it's encompassed in an envelope and it looks on cross section like it's wearing a crown. So due to the Latin, it's a coronavirus. Coronaviruses are actually very easily killed, and that's a very good thing for all of us. They're easily killed with those alcohol-based hand sanitizers and also by just good old soap and water. So you can protect yourself by washing your hands or hand sanitizing very, very frequently. And that's a tremendous benefit during this particular time. It started in Wuhan, China, and they say that it was technically transmitted from a bat to a human. I don't exactly know the authenticity of that, but what we do know is that it moved to a very upscale area in Italy, and it preceded the infectious rate, and the people who were so very, very critically ill superseded the amount of medical care that was available to them. And at that point in time, they had some very difficult decisions to make. From Italy, it moved to the United States. The first cases were technically in Washington state, but it looks like the majority of the RNA and kind of genome mapping that's gone into this, that the majority of the cases that came to the United States actually came through Italy and also came through New York City. New York City is certainly a tourist destination. It's a major metropolitan area where people live on top of one another, and they got hit very, very hard. They never outstripped their medical coverage, which was a great thing. We never want to do that. But it's kind of like seeding a garden. And if you seed it once, you're going to have a pretty good crop. If you seed it about 15 times, you're going to have more crops than you know what to do with. And that's essentially what New York City was dealing with. From there, it was just hotspot after hotspot. And this virus is really a hotspot driven phenomenon and pandemic. So you'll see certain areas like New Orleans, Mobile cropped up as a big time hotspot. Right now, Montgomery's coming back. And what you see there is that people in close proximity with one another doing things like going to church, going to funerals, going to weddings, being in close counsel, are infecting one another. And all it really takes is one person who's got the virus and is either unaware or continues to not socially distance despite their showing symptoms of COVID-19, to pass that along to multiple people. One of the hot spots that really jumped out very early on, even more so than a lot of major metropolitan areas, was Albany, Georgia. There was a funeral there, and I believe 27 people who attended that funeral ended up dying from just being in close contact with someone who flew in from out of town and had the virus, and there we go. So it spreads like wildfire, and if anybody's ever seen wildfire, you know exactly how it spreads. Can't necessarily contain it despite your best efforts. That's something that, as a medical community, we were very, very concerned with this first wave. So what we decided to do as a country was to socially distance and shut down a lot of places that weren't deemed quote unquote essential. In doing so, we did nothing to affect the total number of people who would be affected or infected with this virus. We just slowed the infectivity rate so that we were not overrun as a medical community with these patients who were critically ill with a limited amount of resources. While we did that, we also ramped up production of things like ventilators. We're currently selling ventilators to the rest of the world right now. That's a fantastic place to be in when you're in a global pandemic.
Sure.
We also ramped up our production of PPE, or personal protective equipment, and we're selling that abroad now. I haven't personally encountered a situation where I've not had adequate personal protective equipment for the day. And what that constitutes for us is an N95 respirator, a surgical mask to wear on top of that, some type of eye covering or shield in front of your face. You can wear shoe covers. I personally choose not to, and also gowns to wear when you encounter each and every patient. So that's really been a blessing that we haven't run out of those things. And I think that that's been a very positive thing. I'm technically the chief of anesthesia at Gadsden Regional Medical Center, which is a 375 bed hospital in Gadsden, Alabama. We've not had any staff members, be them doctors, nurses, or environmental services people, who've become infected as a result of contact with either patients or other colleagues. I think that's a tremendous thing that we can hang our hat on. Not that we don't have these cases, we have these people around, and they're people, and you have to remember that. They're not a disease, they're not a virus, they're a person, and you have to take care of the person. Yeah, you can be cautious about their condition, you can be cautious about what they have, but you still have to treat them as an individual, treat the family members the same way, because everybody's scared. So those things that we've done and that have been availed to us have been effective, but it still is there. I think a very rational question for those of you who aren't very familiar with different roles within the medical system is, why is an anesthesiologist talking to me about an infectious disease? Well, we do a lot of critical care throughout our training. Did 8 months of critical care within 4 years, which is a tremendous amount. Your typical internist only does 2 months within 3 years. So we're very in tune with critical care medicine. A lot of what we do on a day in and day out basis is critical care management. And we just may not see those patients over a long period of time. So what I'm sharing with you is the opinion that I possess, the opinions of my colleagues, and also very good fact-based, well-researched opinions that are very short in supply right now. And it's just due to the rapid nature that this progressed. And good research, just like a good vaccine, takes time to develop. So there's a lot that we don't know. We certainly know more today than we did yesterday and a month ago. So we're moving in a very positive direction. And I hope that this conversation really belays some fears and allows people to be more confident in the things that they should do and be more cautious about the things that they should not. So at this point in time, we've basically reopened the state of Alabama. We've reopened a lot of other states, and there are some states that are holding close to shelter-in-place orders. I believe that the initial opening of Alabama was done very thoughtfully and was very appropriate. The second round, which came a week later, I believe was about a week to 2 weeks too early. And then now we're talking about allowing sports competitions and things like that I think are way too soon. And I'm a big sports fan, love sports, but it's not time for that, in my opinion. We were, as a medical community of physicians, looking at the end of May, first part of June as a tremendous second spike. The second spike that will occur in number of cases, and numbers of cases don't really scare me. The more you test and the better that you test, the more cases that you will have. That number doesn't really matter, in my opinion. If I were to tell you that 100% of the United States would be infected with this virus, but no one would be critically ill and no one would die, your infectivity rate then becomes just a moot point, and it's just a statistic to talk about. The numbers that truly matter are the number of patients who are hospitalized, the number who are in critical care units, the number who are on ventilators, and also the number that die. Right now, we're starting to experience an upswing in the number of overall cases, the number of hospitalized patients, the number of ventilator-dependent patients, and the number of patients who are probably going to die within a week to 2 weeks in the state of Alabama, which kind of falls in line with that same timeline that we've been so very concerned with. At this point in time, I'm not worried about running out of ventilators and personal protective equipment. I'm worried about running out of doctors and nurses. You can make new PPE and you can make a new ventilator within a month, but you can't make a new doctor and you can't make a new nurse within that same time frame. And I think that that's what we're really going to be dealing with on the second surge. I think that a shutdown, at least a partial shutdown, is very likely. And I know that that's not good news, but I think it's also a very realistic perspective. So as we look at things like reopening churches and becoming more intimate in a very platonic way, we should all be very, very mindful of the risks that we undertake and that we also expose others to as we do those activities. So I think that's where my mindset is, Mike. Mm-hmm. And, you know, where would you like to kind of guide me?
Well, you mentioned the uptick in cases, and that mirrors what we've heard today, that even though we're starting to see more and more cases, likely because we're getting more testing done and that there is more spread, but we are going to be reopening, as you mentioned, some sporting venues, movie theaters, summer camps, childcare facilities, and so there's more risk. Many of you know, and Dr. Walker and I were talking about this yesterday, that we had graduation at Spain Park last night and then tonight at Hoover High School. And I know there were a lot of safeguards. It was going to be done outside, but that, brings up a possibility of further spread. And so, John Robert, it may be helpful for us to talk about sort of the latest research, maybe the things that just have come out from either FEMA or CDC about how this is spreading. Because at one point we heard that this virus, would last 17 days on a hard surface. People are worried about whether they should wash groceries or not. What's the latest in terms of like surfaces, droplets in the air, at least to the best of your knowledge?
Sure, and I appreciate that. So the coronavirus, or the type of virus that this is technically spread via droplets, which means that if you're walking down a grocery store aisle and someone came right before you and sneezed on a canned good, and you pick it up, you put it in your cart, you touch your eyes, you touch your nose, you touch your mouth, which those are all modes of transmission for this virus, then in that close proximity, you are at very high risk for getting COVID-19. As far as things like aerosolized droplets, which aerosolized droplets are basically where a liquid becomes a gas in the most very basic scientific terms, that only occurs with extreme positive pressure and extreme proximity. So if someone were to cough or sneeze directly in your face, then those droplets could become aerosolized and the virus could be transmitted that way. If you're just in a room with someone multiple feet away from that person or in the same building, you're not going to contract that virus because of aerosolization. However, if you put people to sleep every day and you're directly nose to nose with that patient as you do so, then your risk is incredibly high. So that's our best understanding of the mode of transmission for this virus. That also kind of brings to mind what you should be doing as far as personal protective equipment as an individual in the community. You do not need an N95 to be safe to go out into the community. You can wear a mask, you can wear a bandana, it can be cloth, it can be any type of material. And as long as you socially distance and don't put yourself in very close proximity with people who could have this virus and are then going to expel positive pressure particles, then you're going to be fine. So be very confident in that knowledge. That's very well established. That is not questionable right now. Now, how long does this virus hang out on a surface? There's a lot of theories and a lot of testing that have gone into this. And what we do know is there is this entire theory of what's called viral load. And viral load is not something that you can test. It is the amount of virus that it takes to make you sick and then also to make you deathly ill upon exposure. And there's really no good way to test for that. So at this point in time, it's a very theoretical parameter that we talk about and we throw it around very haphazardly in the medical community, but there's no way for us to quantify it, even though it's a quantifiable parameter. So the amount of virus that is actually present when someone sneezes on that canned good in the grocery store and you come by 4 hours later is most likely not enough virus to make you sick. We do know that. So even though there are virus particles that may hang out on surfaces for 17 hours, 17 days, etc., it's most likely not enough to make you sick. The big time frame is 4 hours. Does that answer your question?
Definitely, definitely does. So you
Good.
already
Good.
mentioned in terms of like what kind of practices we can uh, you know have perform regularly in order to try to protect ourselves. Having a mask, and you said cloth, bandana, whatever is something that would be helpful. What about cleaning groceries? And is 6 feet distance really what we're looking for there?
Yeah, so 6 feet distance is a good parameter. That is a good parameter. And I've found lately, going to the grocery store myself, I've asked people to please back up a lot more. I think a lot of people think that, oh, this wasn't as bad as we thought that it would be. And so now we're just going to go back to life as we once knew it. And that is not the case. This was as bad as we thought that it would be. The mitigation measures that we undertook as an entire country with great cost were effective. And to simply just say this wasn't as bad as we thought that it would be does, number one, it does not acknowledge the sacrifice that we as a nation have undergone. And number two, it also doesn't acknowledge the success of what we did. And I think that's a tremendous fallacy at this point in time, is that people think that you can just go right back to normal and everything is going to be okay. This just wasn't that bad. So I do believe that 6 feet is very appropriate. And yes, cloth masks, bandanas, things like that. I actually had a partner, and this is kind of funny. He said, I never thought that I would wear a mask and walk into a bank and ask for money.
Right.
So, it's a different day. It's a different society. And it's, as it was so aptly pointed out to me today, before the HIV endemic during the 80s, a lot of times medical professionals didn't wear gloves at all when interacting with patients. We still wear gloves every single day. That was part of the way that I was trained. So are N95s going to become the same thing that gloves were then? I don't know. I certainly hope not. I certainly hope that we can come up with a vaccine for this virus. We've never come up with an RNA-based, which RNA stands for ribonucleic acid, and that's in contrast to DNA viruses. But we've never come up with a vaccine that's been successful for an RNA virus. I hope that this is certainly the exception.
So if we're talking about restaurants opening up, movie theaters about to open up, churches are possibly opening up in the next month or so. What are some practices that you might recommend as a physician that we might want to consider?
So I would certainly say, number one, hand washing and hand sanitizer use. That is so very important. And my hands are cracking and bleeding every single day. And you just have to move past the point of discomfort with those, or start to use a moisturizer. And I just don't think that that's something that's in my future. But I would do that. I would certainly wear a mask. And you also have to be aware of the fact that when you wear a mask, you don't necessarily wear a mask to protect yourself from the rest of the world. What you're really doing is you're protecting the rest of the world from you. So when I see people in a store with me and they're all wearing masks, I know that they actually care about me and my health and my well-being. And I appreciate that. And you see somebody who kind of just comes in and hopefully they're not coughing, hopefully they're not febrile, hopefully they're fine, but you still have questions because that mask truly protects the world from you. And that's also why it's very effective if you can get everyone in the world wearing a mask, or everyone in the country wearing a mask and socially distancing. I think we can stay open despite whatever spikes.
Mm-hmm.
It's a matter of not being able to get that type of compliance from people because they just don't understand what is going on, which is the reason why conversations like these are so important.
Sure. Sure. So, you know, in a time like this, I think Christians often feel the burden of wanting life to get back to normal so that we can go to church. I think we feel the burden of wanting to help our neighbor, but we're physically distancing from them. I think that, you know, Christians are also scared. You know, we know God is there. We know that God is working somehow through this, but you know, the longer this goes on, there's anxiety and questions that come with that. And so, you know, you're a Christian, a physician. How do you stay hopeful, or where do you find the power or trust to be able to continue to go right to the front lines every single day?
Mike, I think that's a really good question. And anxiety and fear and restlessness,
Mm-hmm.
and the knowledge that what we're undergoing right now is something that none of us have ever experienced before.
Mm.
The last time that we as a country experienced some type of global pandemic was 1918, so it's 102 years ago. There have been a lot of people who've been born and died in that same time frame and never knew something like this. There's still, you know, a few who were probably very young, so I'll acknowledge that as well. But these are not times that are unknown, and they certainly are not unknown to God. The level of technology, the level of medical expertise that we possess today so far outstrips what they had even then. And we are able to understand things so much more and so much quicker than they were at that point in time. So I have faith in the system and the people that God has essentially endowed with building,
Mm-hmm.
that we have built since that time frame. And aren't we so much stronger and so much better off and so much more cared for than even those back then?
Mm.
The other thing that there are several scriptures that I've really taken to heart since this whole thing really became a thing. And you can talk about David and Goliath, and I think that that's a wonderful metaphor as an individual versus something that won't blink. You as an individual and as a person, you can blink and you can run. This thing won't. It will just invade. And I was, quite frankly, very anxious about this because it was new. It was something that I'd actually never had training on. We don't completely understand this. What's to be believed, what's not to be believed. And you understand that it's bad. You understand that it has the possibility to overrun entire health systems. And as a physician, that's a terrible decision to make, not to put someone on a ventilator who potentially might succeed because you're choosing between that or someone younger. That's an awful place to be, and thank goodness we are not there. But I anticipated being there, and I'm just so very, very glad and thankful that we're not. But one of the scriptures that I've held tight to, and a very good friend of mine brought to light an excellent point. When you're talking about putting on the armor of God, and you have the breastplate, you have the shield, and you have the sword. There's only one place where you're not protected, and that's your back. So if you go into battle and you turn and you run, you're not protected. But if you go to battle and you face down your enemy and you call them by name, you are, come what may.
Wow. I've never thought about that. Your back is completely vulnerable. And if we're, as Christians, as people in the community, if we're supposed to be loving our neighbor, one of the things you said was wearing your mask is just as much about protecting others from what we might be carrying and just not know it. So this idea of sacrificing a little bit to wear a mask, just so that you can truly love your neighbor in service and in action, seems like something that Christians will be ready to do. In fact, I think I mentioned this to you yesterday, that we polled our congregation and we had about 102 responses, and over 95% said that they would really be willing to wear a mask in worship. That shows that people are at least taking this pretty seriously.
Well, I think that's a great point. And I hearken back to that Spanish flu epidemic of 1918.
Mm-hmm.
At that point in time, I don't know if you're aware of this, Mike, but there were preachers in Birmingham who actually sent their sermons in to be published in the newspaper so that they would arrive for their congregants. Hasn't technology come so very, very far? And isn't that a blessing during a time like this, that we can have a phone call like this? We don't have to sit in the same room. We don't have to do those kinds of things. You can have church over the internet. And what a blessing that is.
Mm-hmm.
And I think that to say, could we push this? Yes, we could. Absolutely, we could. And you'd be well within your constitutional rights. But we had a group up here in Gadsden, in Etowah County, and it was a pastor and several members of his congregation all died because they decided to defy the shelter-in-place order. It was a pastor, his wife, and I think several members of their congregation who all died. And you just have to be aware of the, again, platonic intimacy of worship services, funerals, weddings, those kinds of things, and just be aware of those consequences. Is that really a consequence that you are willing to bear? Can we not be a community of believers virtually for another month so that this can dissipate even further and we can get on down the tracks? Is that a sacrifice that we can make? And sometimes the answer may be no. No, that is not a sacrifice that we can make. And that's perfectly acceptable as long as you go into it with your eyes wide open.
Sure. So we had talked about a time for question and answer, and I think we'll do one round of question and answer where we're still recording, and then we'll stop the recording for any other questions and answers. Now, just be aware that many of you are muted, and that was the right move to make during the first part of this. And in just a moment, if you're ready to ask questions to Dr. Walker, I know he would be happy to do that. But before we do that, John Robert, is there anything else that you would like to add to this conversation before we open up Q&A?
Sure. I think probably the last thing that I would like to say as part of my little diatribe here is that if you become infected with this novel coronavirus and get COVID-19, chances are you are going to be okay. Your loved ones, if they become infected, chances are they are going to be okay. There's risk factors that increase that risk, but we're not talking about a flip of the coin, and we're certainly not talking about a death sentence. Are we talking about something that we should be all so very, very cautious about and aware of, and also try to mitigate our exposure as we reopen things and become more of a quote unquote normal society? Yes. The answer there is absolutely. But this is certainly, it's something to appreciate. It's something to be aware of, but it's not something to be in fear of. And that would kind of be my last thought.
Well, and that reminds me of the scripture that God didn't give us give us a spirit of fear, but of power. And so there's something to think about there. Thank you so much. And so I'm going to see if I can just unmute everybody. And if you have a question, just speak up, and I'll try to help organize this as best I can.
Yeah, Mike, this is Jim Wilson. How you doing, John Robert? You still on?
Jim, it's good to hear from you, man.
You too. You too. John Robert, can you talk a little bit more about the difficulties of coming up with a vaccine, and maybe some kind of percentage that you think might be appropriate for saying this is a percentage that they will not be able to come up with a vaccine?
So, Jim, at this point in time, I think I kind of spoke to that already. We've not been able to do it for an RNA-based virus before, okay? And just to give you a point of reference, the common cold is actually a coronavirus, okay? But I would like to take your question and maybe transition it to testing, because I don't have good numbers on. I do think that there's certainly, number one, there's a market for this. There certainly is a massive need for it, and there's also a tremendous amount of academic and knowledgeable research drive to get there. And it's something that I've never experienced. It's almost like sitting on top of an airline engine. They want to get there. So if we can, we'll do it. Okay? But as far as numbers are concerned, I don't think that there's anybody who can quote you a reliable number from the president on down. Okay? So let's talk about testing just a little bit. There's two different ways to test. There's testing for an active virus, okay? And there's also antibody testing, which shows that you've been infected, all right? So at this point in time, the testing for the active virus is about a third not relevant, okay? So that means that a third of the people who will be tested and actually have the virus come back negative. So that's it's a bad test. It's a really bad test. We're working on perfecting that, but right now the testing is very poor. The antibody test, which shows if you have been infected and now you have immunity to it, is actually worse than that. And that can be very well studied. The other cannot be, because we know who had it, we know who's gotten over it, and we know that their antibody tests ought to be positive. So part of the reluctance in testing is not necessarily a shortage. It's just a matter of the test isn't very good. And there's not much that we can do other than continued research and development to improve that. So excellent question. I wish I had some numbers to throw at you, but I just don't think that anybody's got those right now.
Thank you, Jim. Are there any other questions?
Hey, Mike, this is Mark Torres. One of the things I was
Hey,
wondering
Mark.
about was early on, we heard about a large percentage of those people who were contagious that had no symptoms. Is that still the common thinking, that there is still a large number of people who walking around can give other people the virus and they have no indication they've got it?
Absolutely, it is. Okay. So one of our facilities that we provide anesthesia services, it's in Marshall County. Marshall County has actually been a hotspot due to the majority of the chicken plants in the state of Alabama being located there, and the type of work that they do being elbow to elbow in close proximity. And it's mostly immigrant type workers. They got infected at a very, very high rate. So Marshall County screens all of their elective surgeries with COVID testing. And out of 100 patients on their first batch, 10 patients came back positive and had no symptoms. So that is 10% of that population. That is a tremendous, tremendous risk. And again, it further echoes the need for people to wear face masks, not for yourself, but for other people.
Thank you, Mark. Anything else? Any other questions?
Hey, Mike, this is Benny Vinson.
Hey, Ben.
And John Robert, I know there's the, what's the N95 is the mask that is supposed to be the best. And I see all kinds of variations of masks, some of which I have and people that I run into. Are the ones that seem to be not so scientific, so to speak, are they still effective in what they're meant to be worn for?
So Benny, that's a great question. And I'm gonna kind of work from the top down on that question.
Okay.
The N95 means that as you wear it and wear it properly, which is a difficult thing to do. My parents would tell you that for the last several years, I've had a beard. If you have a beard, you cannot wear an N95 properly. You have to shave your face. You have to have a good snug fit, and you also have to be fit tested with that N95. The majority of the population that's running around these days wearing N95s aren't wearing them appropriately. So basically, they're just as good as any other bandana, cloth mask, surgical mask, etc. Now, as they're designed, the N95 stands for a number of particles that 95% will be blocked out by. And when you wear one, it's like breathing and talking inside a cardboard box. It's not the most appropriate thing. It fits very snugly on the face, and it's not comfortable. It's not a very pleasant experience. I disliked them before this. I dislike them now. And now kind of my company line is the only thing worse than having to wear an N95 is not having one to wear. But your other masks are very effective against non-aerosolized particles, which I'll reiterate kind of what that means. With droplet precautions, which is the main transmissible or the main mode of transmission for this virus, you're perfectly acceptable to be wearing any other type of mask, whether it's a homemade cloth mask, a bandana, or some type of surgical mask that you've been able to get your hands on. The only way that you truly need an N95 is if you believe you're going to be in direct contact with aerosolized particles. To take that step one further, the usual way that we breathe is through negative pressure. Essentially, the chest expands and we suck in oxygen like a vacuum cleaner. When you breathe with positive pressure, or you have positive pressure applied to the airways, it's in coughing, it's in sneezing, and it's also in certain medical conditions where we actually breathe for the patient, either with a bag mask or with a ventilator machine. Unless you believe that you're going to be in direct and intimate contact with those patients who are infected, then you don't need an N95 at all. So everything else is perfectly acceptable. Maintain your social distance, wash your hands a lot, and just be confident in the fact that you're going to be fine. Again, that mask is far more protective for the rest of the world from you than it is for you from the rest of the world.
And John Robert, this may be overkill, but one of the things that my family's been doing is that we have several of the cloth masks, and we end up, after a single use or a day's use, throw it in the washing machine, wash it, dry it, then we've got it for another day. Is that overkill?
Absolutely. No, that's not. And I would certainly advocate doing that. My typical practice now, when I go to the hospital and we take care of these patients, we actually took care of 3 yesterday who were either COVID positive or under investigation, highly likely to have it, is that I show up to the hospital, I change into hospital laundered scrubs. At that point in time, I put on a cap, I put on a mask, and I also get my N95. Then I wear a grinder's or welder's shield in front of my face, and I do that throughout the course of every day. At the end of the day, take those off, change back out of the hospital laundered scrubs. I go home, I put my scrubs, my home scrubs, directly in the washing machine, and I directly go take a shower. That's how I pursue every day, knowing that I'm in contact with these folks. So I would advocate some type of modification to that, because I'm certainly at a lot higher risk than I think most folks on this telephone call are. But that's a good practice. And as I said before, we've not had any of our folks to come down with COVID as the result of a patient exposure. And I think that's a tremendous success, particularly when you look at the type of work that we do, which is very intimate, as I said before, and it's also high risk. So you guys are not nearly at that same risk level, but you still have to take the precautions that you see fit.
Right. Any other questions?
What are your feelings? This is just a minute. This is Olivia Howard. What are your feelings on the antibodies, and if the antibodies actually protect a person from being reinfected?
To my knowledge, we don't have anyone who's been reinfected. It looks like your immune response to the virus is very successful at precluding future reinfections at this point in time. That's a big caveat. It doesn't mean that if you get COVID, then you're going to be fine for the rest of your life. These viruses mutate. They change every single year. It can be like the flu. So there's a possibility, as with Jim's question that he raised, that we could potentially have a yearly COVID vaccine, just the same way that we do with the flu. The flu is also an RNA virus, and it is highly mutatable. So hopefully this virus does not play out that way, but it certainly has the potential to do so. But at this point in time, If you get it, you're not going to be reinfected in the short term. We'll see what the long term has to bear.
Any others?
This is Benny again. I got one more question. You may have covered this. I had to leave for a minute while you were talking, but there's a question amongst a lot of people that I run into about the benefit of wearing gloves. I've heard that they can be a protectant for you, but then on the flip side of that, I've heard that they can also be a contaminant in that the gloves carry off everything you've touched. And what's your thoughts on that?
So when I go into public, I do not wear gloves. I do wear a mask. The big thing as far as contamination is concerned is touching your eyes, nose, or mouth. So if you wear gloves and you touch something, and I'll go back to my same canned good analysis or analogy in the grocery store. If you touch a contaminated canned good and then you touch your eyes, whether you're wearing gloves or no gloves, you're going to get the virus, most likely, if that contamination occurred within a short period of time. So yes, those gloves can certainly carry contaminants. I think the best practice at this point in time is just to hand sanitize and hand wash very frequently. I probably hand sanitize or hand wash in the neighborhood. When I'm at work, it's probably about every 5 minutes. When I'm in the community, it's probably about every 20. So you'll be okay if you choose not to, and you'll probably be okay if you do choose to wear gloves, but just be aware of those modes of transmission that exist.
Okay, thank you.
John Robert, Andy. Can you hear me?
Yes, I can.
Yeah.
Speaking of vaccine, are they doing research now on trying to come up with a vaccine for this COVID virus, or are they more looking at
Oh my God.
a cure or something to actually stop it?
So at this point in time, as a medical community, we're looking at both. We would love to have a silver bullet, and that would actually truly change the entire trajectory of this infection.
Be there.
But a vaccine would as well. And so we're looking at both. There's a lot of ways that you can look at drugs to treat things as far as a cure. Really what's going on right now is what's called high throughput technology, which is where you test a whole host of drugs that you have no idea. They're already established. They're good drugs. They've already been proven out, and you test them against the virus and see what works. And I think that initially that was kind of where the hydroxychloroquine potential was seen. And then you can also set out to do what's called novel research, which is where you attempt to develop one drug to fight one pathogen, which is what we have. So we're still undergoing that same high throughput technology. They're still pursuing one drug to treat one pathogen, but they're also doing their best to develop a vaccine. And we hear things the same way that the public does, and it'll either prove out or it won't. My hope is that we can get something and we can get it soon, but also realize that there's a lot of challenges with an RNA type virus.
Well, I think what we might want to do at this point is transition to a Q&A off the recording. And we're going to hopefully make this recording available to the rest of our church family very soon. I do think that there may be a question or two that people might want to ask when the recording stops. You don't have to hang up. You can stay right on here. Don't forget that you can use the chat function to contact either me or post to everyone so that you can ask a question if you don't have a microphone or if you don't feel comfortable asking that. Thank you everyone who participated, but most of all, Dr. Walker, thank you so much for your time. You've been so generous, thorough, and helpful in this whole hour that we've been all together. And I just want to say thank you for being such a good man and for the level of care you provide on a daily basis. And I know that this church is proud of you and everyone that has come through our church and entered into such an important area of medical care and help to the community. So thank you very much.
Thank you, Mike. I really appreciate it, and I'm certainly willing to hang out and answer any and all questions. I also just want to say, just how proud I am of coming from Bluff Park Methodist Church, and in particular, the number of physicians that have come out of that church and that congregation is truly astounding. And it really speaks to the type of people and also the environment that everyone has created to be so very nurturing to who I would like to think are good folks. So thank you as well.
Amen, John Robert. That's JP. Amen, John Robert. You got it, buddy.